Thank you. Assalamu alaikum again. Another topic, we will talk about the diabetes remission post laparoscopic sleeve gastrectomy. We all know that the trend was to treat patients with diabetes and obesity with malabsorptive procedure, and due to high volume and preference of the patients, now even the diabetic patients are preferred to do laparoscopic sleeve gastrectomy, which give us a chance to look at the effect of laparoscopic sleeve gastrectomy on diabetes. There have been multiple studies about this, the effect of sleeve gastrectomy on diabetes, with multiple different results. In this study, we looked at the effect of sleeve gastrectomy on diabetes in our center, and to study our population in Saudi Arabia and Middle East, how they react and what's the effect of sleeve gastrectomy on remission of diabetes. So, as we know, all the diabetes, the obesity is the cause of diabetes, a primary cause, and the bariatric surgery is an effective measure or procedure for diabetes. It's a retrospective study with 81 patients with type 2 diabetes who underwent bariatric surgery, inclusion from 18 to 70-year-old patients with type 2 who underwent a primary surgery from 2009 to 2016 with confirmed diabetes. Data, we have our own registry in bariatric center, which makes it really easy for us to obtain the data, and we analyze it using the SPSS system version 21. So we use the well-known criteria for diabetes remission based on the American Diabetes Association, with a fasting blood sugar more than 7.3 millimole per liter and hemoglobin A1C less than 6.5, and stopping all medications. Improvement considered if the hemoglobin A1C decreased by 1% and fasting blood sugar decreased by 1 millimole per liter. So here is the demographic data of our patients. We had an 80 patients with an age of 48-year-old, male to female. Male is 43% and female 56%. BMI was 45, and duration of diabetes, the mean duration of diabetes preoperatively was 10 years plus minus 7. Hemoglobin A1C was 8.5 plus minus 1.6. Fasting blood sugar 9.4 plus minus 3. This is our result. We had an 80% of patients, we followed them for 2 years post-operatively, and we found that 80% of them had remission. They stopped all their medication. Their hemoglobin A1C is less than 6.5. Their fasting blood sugar is less than 7.73. 20%, the remaining, they have improvement. All of them. So here we go, the clinical and biochemical characteristics of the patients. BMI decreased from 45 to 33% postoperative. Hemoglobin A1C reached to 6.2. Fasting blood sugar reached to 5.4%. Oral hypoglycemic medication was taken by 59 of the patients. The other 21 patients, they are taking an additive as insulin. 72 of them are off medication. Here we see the diagram on a follow-up of the first 6 months. The peak of stopping all the medication of oral hypoglycemic treatment is in the 2nd month. Interestingly, during the first month, most of or let's say 8 out of the number of the patients who were on insulin stopped their insulin in the first month. So we compared the participants who had remission and those who had improvements with the duration of diabetes preoperatively and hemoglobin A1C and fasting blood sugar, plus the BMI. There was a significant correlation, between the patients who had remission and improvement in terms of duration preoperatively. The patients who had improvement had around 17 years of diabetes preoperatively, and the patients who had complete remission had a duration of mean of 8 years preoperatively. Hemoglobin A1C also, who had more than 8, around patient who had around 8 of hemoglobin A1C had remission. The one who had around 9 hemoglobin A1C had improvement. So this gives us a hint of that we have to treat the patients a bit earlier to get more remission. Same applies to fasting blood sugar. Remission was in patients who had remission had 8.8 of fasting blood sugar, comparing to patients who had 11.7 fasting blood sugar only had improvement. BMI, there is no differences. Whatever the BMI preoperatively doesn't correlate with the remission, predicting as remission postoperatively. Here we go, the results, the postoperative result. The mean of hemoglobin A1C in remission was 5.9, improvement who had around 7.5 hemoglobin A1C, fasting blood sugar lowered to 5.15 for the remission, to 6.7 in patients who had improvement. The BMI postoperatively was almost the same in two groups. So the patients this is comparing the preoperative duration of diabetes. All the patients who had diabetes during the last 5 years, 1 to 5 years preoperatively, had complete remission. And this number decreased with as long as the preoperative diabetes duration increases. So the earlier, the better. Patients who diagnose diabetes, I think that should be referred to bariatric surgery as soon as they agreed to go for the surgery. So this results give us a hint of what's going on these patients who undergo laparoscopic sleeve gastrectomy, as we thought that maybe still the malabsorptive procedures are better, but we are having an impressive results in patients who underwent laparoscopic sleeve gastrectomy. And this result may need to be studied in a long term, more than 5 years, 10 years, and see how the diabetes, if it comes back or still in remission. There's an excellent result, and I think it should be offered to patients who would like to go for sleeve gastrectomy and who have diabetes. Thank you.
Thank you, Dr. Saad. We have 2 questions, so allow 2 questions for Dr. Saad. Okay, go for it.
What's your take on recurrence of diabetes?
Yes.
How do you see that?
Yes, actually, this is what I just mentioned before, that long-term effect should be followed. There is no much data on the long-term follow-up. There is a couple of studies that are studying the long-term effect with different results from region to other region. In our region, we don't have a long-term follow-up for these patients, and we need to do more study for a more than 5 years follow-up of this patient to see if it's the diabetes came back or they are maintaining on remission. I think this is another point that we have to look for on these patients with a long-term follow-up, and we are following them to see what's the effect.
Don't you think that makes us stress on the fact that patients should have a close follow-up, diabetic patients in special, where they have psychiatric follow-up, endocrine, dietitian, and so on? Because we found in the IMC, in the private centers, that patients are reluctant to come and follow up because that costs money.
Yeah.
So I think there should be a national consensus where governmental centers has to take over even patients who are operated in private, because a lot of patients now being operated in private, and they are reluctant to come back to see a dietitian that will cost money, a psychiatrist who is, or a psychologist who's involved in eating disorder diseases, and endocrinologists and dietitians. So they are reluctant to follow up. And those patients, we see them after 6 and 7 years with relapse of diabetes, actually. The big number, I don't have statistics in that, but we see them.
Yeah. Actually, we have a good number of patients here that we are following up. Yes, I think I agree that we have to have a close follow-up, and we have to know the effect on long term for the diabetes. We are doing now the follow-up for these patients and see the effect on long term. I think we have to collaborate with our friends in the endocrine service, because they are following some patients who are operated in private sectors, but we were not aware of that. I think if we collaborate with them, we will find a lot of patients who did the surgeries somewhere else and they are following, and we can share the result with them and see how is the long-term follow-up. I agree.
Assalamu alaikum. I'm Dr. Mufaddal from India. I wanted to ask you two questions. One is that, did you see the same results irrespective of the severity of how many years of diabetes that patients had? Second thing is, did you look at things like insulin use, C-peptide levels, and various other things as your markers? Because some of the worldwide studies are completely different from what your data suggests. Your data suggests that irrespective of what procedure you do, especially the BPD, the results are the same. So what's your take on that? Have you looked at number of years of diabetes, insulin use, various other cursory markers, and whether the results are the same?
Yeah. To compare other procedures with sleeve gastrectomy, as we just mentioned, we need a long follow-up. This is a short follow-up, like a 2 years follow-up. The result I'm showing is only the follow-up for 2 years. So if we would like to compare to other procedures, we need to have a long follow-up to compare it with the already published result of long follow-up in other malabsorptive procedures. Regarding the preoperative severity of the diabetes and the effect on remission, yes. As I show on the table, the longer the patient was on diabetes, the higher the hemoglobin A1C, the higher the fasting blood sugar, the less likely the improvement. The shorter the period preoperatively, the better the numbers of hemoglobin A1C and fasting blood sugar, the better the result. And the patients who had diabetes the last 5 years preoperatively, they have 100% remission, at least during the follow-up of the 2 years.
Are you aware of the Cleveland severity score, the latest score that has come out?
Sorry.
Even compare your patients that way?
Yes, we didn't use this Cleveland classification, but yeah, maybe we'll consider it on our long-term follow-up. Yes.
Thank you.
Thank you very much.
Thanks, Dr. Mufaddal. Last question.
My question is actually, now you say that so the earlier you send the patient with uncontrollable diabetes mellitus for surgery, the better will be the remission.
Yes.
What's about so the cases so you get it less than 35, the BMI,
Yeah.
and the with uncontrollable diabetes mellitus, and the patient is asking actually or seeking for help,
Yeah.
and it is the history, family history, and less than 2 years or so the diabetes mellitus.
Yes, there is multiple studies. There is a couple of studies actually about the low BMI patients with diabetes who offered surgery. But in our study here, we just included the patients who are having more than 35 BMI. I think the results are promising for the patients who have less than 35 BMI, and it's already published with good results. I think this group of patients, at least from 30 to 35, they also should be included in the criteria for operation. I agree, I totally agree, and there is a good published result about this.
And those with the BMI less than 35, would you recommend for them a sleeve gastrectomy or bypass?
Still, there is no answer for this, but on long-term follow-up, if the effect on the higher BMI patients on sleeve gastrectomy is good, I think this patient, by default, they should be offered sleeve gastrectomy because their BMI is not really high.
Okay, next speaker.
Thank you.
Thanks, Dr. Saad.